patient to be able to indeed measure GFR in terms of 61% could not. And these were things that brought to light that probably we even support some of these hospitals to be able to do what that which is right. So I keep seeing less patients coming in with end stages or probably with needing dialysis. And again, most of them actually mentioned that they need training. And again, that is why this call is very important. And this program by Actors is extremely important because we are able to now this time around. These patient groups do you routinely screen for CKD? So we have just about seconds. So clock in your answer quickly, and then so we can move on. Which of these patients do you routinely screen for CKD? We probably have about 15 seconds to go, so wherever we get to, at least we just get a fair idea of the pool so we can move on. Okay, so it's exciting to 74% of you are saying you screen all of the above, which is actually very exciting, and I'm wondering what exactly you are saying, because then that would be exciting if all of these patients are actually screened, in terms of patients with hypertension, patients with cardiovascular diseases, those who get older, family history of kidney disease and all. So all of the above. Okay, so now what does KDIGO? So KDIGO is Kidney Disease Improving Global Outcomes recommendation in terms of screening. And we need to screen, again, like most of people, right, hypertensives, diabetics, patients with cardiovascular diseases. But again, it is clear that you need to look out for other risk factors like obesity, ethnicity. So black race is actually a risk. Patients who are older, most guidelines will say 60 and above, but I'm afraid here in Ghana, for instance, the average age of kidney failure is about 47 years. So I advocate that at least 40 years and above should get screening done. Family history of kidney disease, a family history of diabetes, hypertension, and so on and so forth. Everybody, almost everybody in our part of the world probably might introduce themselves or might take some herbal medication or some nephrotoxin. And again, some genetic factors people might not be aware of, or a proud history of acute kidney injury. This is actually very important in a sense that it doesn't even cover for all. So what I say in my practice is that virtually almost every patient I see, as a nephrologist, is a high risk because a lot of them don't even know what they have been exposed to. A lot of them don't even know their family history and so on and so forth. So we need to have an aggression to screen for kidney disease. Now, should we screen for kidney disease? That doesn't qualify to be part of the Wilson and Jagna principles of screening. So for something to qualify for screening, it should be able to satisfy these 10 points. And we'll try and go through and find out whether chronic kidney disease qualifies. Now, whatever it is that you want to screen for should be an important. I need to convince you hard enough that chronic kidney disease is such an important. The next thing is that the natural history of the condition, including the development, should be understood. We know so clearly how it happened from the beginning and in terms of proteinuria and probably the risk factors. So we know that if you're able to handle it well for progression, it has to have a recognizable latent period. And like I said, in most cases, early stages of chronic kidney disease is asymptomatic. It should have a suitable test, which I'm going to talk about very soon. Simple test, urine, you should be fine. And that test should be acceptable. Invasive at all. Getting a urine sample or getting a little blood sample, it is not invasive. And there should be an agreed policy of whom to treat. And obviously, I'm going to show you who to treat as far as when we pick up in terms of stage of kidney disease, who you can treat and who you should not treat, of course. I mean, if you pick it, you probably may need to treat. And then again, there has to be diagnosis and treatment available. And I'm sure by the end of this webinar, you are going to know some of the medications that have been a lot of strong evidence that helps us to prevent progression. And the cost of case finding should not be too much, of course. So it will take a cost an arm and a leg to screen for, but you can realize that you'll probably not cost $40. But then it's going to actually cost you about $60 per session of dialysis. So again, it is actually cost effective. And then case finding should be an ongoing once and all. you probably need to keep doing it over and over again. So I hope I've been able to satisfy you that chronic kidney disease satisfies all of these conditions by the WHO for a case that should be screened for aggressively. Now, we have peculiar situations in low and middle income countries in the sense that good health system or probably our health systems are very weak. So if you have a health, people are being asked to come for reviews frequently. There's a wellness center. People are being checked for diabetes, hypertension. Probably some of these things will be picked a bit earlier, but we don't have that. And unfortunately, a lot of people are ignorant about kidney disease. And so a forum like this helps us to be able to encourage patients, to encourage their patients to read and know more about kidney disease. And again, how about those silent risk factors, I call them? Do you know that low birth weight, for instance, is a risk for kidney disease, hypertension, and all? How about the use of herbal medications, which I mentioned? Our people use things. How about the painkillers that the old people are using for their joint pains or their back pains or their headaches without seeing a healthcare provider? These are all things that causes us to see cases that you should have a high index of suspicion for looking for and treating patients with kidney. For I believe wherever you practice, you need to tailor your risk assessment to your setting. You probably might find that there are particular groups of people coming with end stage or coming with advanced cases of for these people, treat them population-based screening. And I ask that sometimes if you are talking about the cost-benefit analysis, who is actually doing the pay? In my part of the world, where I am, where the ordinary patient pays for their cost of dialysis, which will probably be about $60 or $70 per session, and you'll need, let's say, about 3 times a week, which will probably be about $200. And it's actually going to cost you, let's say, $15 to get yourself safely. Please, if you are the one paying for it, I think it will make sense that you screen yourself so you didn't have to cough up that amount of money, for renal replacement. So again, who is paying for it? Now, we did this study trying to look at the socioeconomic impact in low and middle income countries in Africa. While we're trying to pick up risk factors, all just because of our poverty or probably because of the fact that there's low socioeconomic status. And we realize that across the life course, from prenatal, before you are born, through childhood, adulthood, and the elderly, there are risk factors that keep beckoning one way or the other, and it's actually compounded because of course, low socioeconomic circumstances. Meanwhile, there are some underlying things that cuts across from poverty, low educational level, weak health systems, like I've mentioned, low nephrology workforce, very few nephrologists in some parts of the world, and then of course, poor health financing, where people are. So all of these things makes it very worrying for people in low and middle income countries to sit back and say we are not at risk, because low socioeconomic condition alone is a risk of chronic kidney disease. And I think that's what this paper of ours trying to show. So I pick up simple things. If you are above 40, if you probably are Black, if you have a sedentary lifestyle, or probably you have a history of diabetes, hypertension in your family, you are most likely at risk of kidney disease. And your patients has these factors, they are most likely at risk of kidney disease. So please screen, screen, and screen. Now, another poll. Can we answer this? Does your clinic run both the EGFR, and UACR testing? That is the urine albumin creatinine ratio. Is it yes? Is it no? Is it only EGFR or is it only UACR? I've been able to give you what my people back at home actually responded to. I want to know what the situation is where you are. All right, so just about some 30 seconds to throw in your answers. Okay, I believe for want of time, if we answer, so probably just give some 5 more seconds and then we can get going. And I'm hoping to get good answers from you. And hopefully, if you are not, the advice is hopefully after this presentation, you'll be able to take advantage to screen your patients. How it gets the results. Thank you very much. All right, so majority, which is actually not greater than 50%, so 44% are actually saying that yes, the EGFR and the UACR. Some 17% are saying no. To be able to encourage those who said no to be able to do it. And if there are factors that is happening, you talk to your healthcare administrators to be able to do that. Only EGFR about 33%, and then only USTR about 6%. So again, this actually shows that there's a lot of work that has to go into ensuring that we our patients. Thank you very much for the. Now, what does kidney disease improving global outcomes recommend? All right, so the recommendation is the fact that we need to monitor our patients' EGFR and UACR. So the 44% are doing things right, the rest of you will need to work on it. And the point is that if you screen your patients with the albumin and the EGFR, you're able to place them in this heat. That will help you to know how often you should screen them. But what I will say is that the guidance to the frequency, in my opinion, depends on your setting. Sometimes you might see a patient who might have with an acute kidney injury in addition. You might probably need to screen them a bit more frequently than others. But nonetheless, this is a guide in terms of how often you should screen. So if probably you are in this category, probably once a year is fine. If it is the what is the orange, then probably twice a year is fine. As you get darker, then probably you need to screen your patient a bit more frequently. Now, why is this intervention very important? So I'm showing you this study that actually shows that for people without albuminuria, normal aging, this is actually the line at the top there. Probably they'll live their lives and they die off from something else and not kidney disease. But nonetheless, if there is albuminuria and there's probably impairment of renal function and you don't do anything, they are most likely to die. Now, the point is that if you are like most people who would wait for symptoms, you are going to intervene when it is late. And indeed, you probably are going to cut short the to do that. But nonetheless, if you're able to screen them early, the chances are that they might live as long as those who probably are not having albuminuria, even with the before requiring renal replacement therapy. So I actually tell my patients that my hope for them is that though they have kidney impairment, they probably will die from something else and not necessarily the kidney disease. So we need to be very particular about this. Early screening is so important. All right, so this is actually my last. So probably this would be more relevant for those who are actually doing both. But the point is that how often do you do that? So let us know how often you do it. Rarely, routinely, once a year, twice a year, or if you see symptoms. And let's get honest answers here so that we can see how best we can improve your care and management in your setting. How often are both EGFR and urine albumin creatinine ratio measured in your patients? Okay, so can we see the answers? Okay, do we have some answers in there? Okay, so 12% are saying rarely. Thank you very much. Routinely, so once a year is actually the one that is the majority, which some 30% are saying twice a year. And again, some are saying when they see the symptoms worsen. And then, of course, some are not even performing it. So again, we can see that as per the response of work that we all need to do. And I'm advocating that, of course, I mean, depending on your patient, you probably may need to screen at least once a year and probably more, depending on the stage of CKD and the risk factors the patient has. Thank you very much. Now, I'm going to be wrapping up with what the KDIGO. So there's actually a toolkit, by the ISN. And again, I'm happy to say this sponsored by AstraZeneca, where we looked at the CKD early identification intervention toolkit. So we talked about, of course, the issue of CKD being a global burden. We've discussed the risk factors, so you know now what the risk factors are, and I believe you have your own facility or country for which you should screen for. And we've actually mentioned the key things that you're supposed to do. So creatinine is a simple one. If you have cystatin C, that is even a plus. But of course, if you don't have it, at least basic creatinine and urine albumin creatinine ratio is excellent. And again, the ISN actually advocates that even if you don't have it, a simple dipstick is also relevant. So again, this is something that is for all. If you have it more, you can still do all of that. If you don't have a lot of it, you still can do what you have. But the point is that let's do something. I think that is where I would want to put. So I've shown you this heat map that helps you to stratify how often to screen. But the beauty is that when we screen our patients, we are able to clearly do a lot of interventions that prevent progression, lifestyle modification, smoking cessation, optimizing blood pressure control, glycemic control, of course, SGLT2 inhibitors, RAS inhibitors, statins, treating metabolic acidosis. So all of these things are interventions that when you put in place, you actually prevent your patients from getting worse. So it is so important that we pick early, actually come to realize there are some patients, you just tell them, stop taking that NSAID alone. And you realize that all of a sudden their kidney function stabilizes and actually improves. So it is so important that we pay particular attention to all of these things to be able to let our patients live longer. Now, having said that, all of these things are available for us. ACE inhibitors, one of our good old drugs that have been so available, but unfortunately, 80% of people who need it don't get it, and that's actually worrying. So we can make a case that SGLT2s are expensive, they're not available. But I believe ACE inhibitors, ARBs are in most places. But again, physicians are giving all sorts of excuses for not giving it. I'm worried about the potassium, I'm worried about hypotension, my patient is that, my patient is that. Now, the key is that we need to know that this is actually one of the medications that have been shown. If you get hyperkalemia once, try and see if you can deal with other things and get a good reason to throw your patient back on that ACE inhibitor, or else we are shortchanging our patients. But nonetheless, other prescriptions are available, but obviously, even if ACE inhibitors, ARBs are struggling, you can imagine. So as per this study, DPP-4s only 0.06 are being used as GLP receptor antagonists, which has also been shown to decrease inflammation and prevent progression, is also used so less. Now, SGLT2 is such a very big worry. In my practice, most patients who started after 2 months, 3 months, they are off because they cannot just sustain themselves. So AstraZeneca, listen to us and listen to our patients and see how best we can reduce this medication to ensure that our patients get the best as we screen them. Because if you screen them and you cannot prevent, then it becomes a problem in terms of the screening. Having said that, there are so many drivers of disease progression in terms of inflammation, hemodynamic dysregulation, and hyperglycemia. There are medications that have been shown to prevent progression. SGLT2 is so important. ACE inhibitors, ARBs have always been important. Let's put our patients on. And now the non-cortical receptor antagonists are also coming in. To all of these are medications that have been shown to prevent progression of kidney disease. So we need, though some are not available readily, the ones that are available, let's maximize and use. And of course, we hope to speak to people who matter to reduce the prices of the ones that are too expensive for our patients to get the maximum benefit. In summary, chronic kidney disease is such a global burden and to continue to rise. But unfortunately, we need to diagnose because many of them are undiagnosed. Some patients are at high risk of developing chronic kidney disease. Hence, screening in primary care is so important, and that's why this fora is very important. Screen your disease. For us as nephrologists, the earlier you screen and pick them, the better for us. With EGFR and UACR is essential, and again for diagnosis and their management. But early intervention, like as we said, with RAS inhibition and then SGLT2s are so recommended. But when we delay, they don't become too useful. So early treatment is so important. At this juncture, I want to thank you so much for your time and attention. Thank you very much.
Thank you, Professor Daniel, for the nice slides from your country and from Africa. Thank you a lot for the excellent presentation. So our next speaker will be Professor David Wheeler, and Professor Wheeler is a professor of kidney medicine at the University College of London and honorary consultant nephrologist at the Royal Free Hospital. Scientist interested in CKD, he has participated in the development and delivery of several large-scale clinical trials in nephrology, including SHARP, EVOLVE, Pivotal, Credence, DAPA-CKD, and the HTAC stabilizers in the ASCEND trial. He's a co-chief investigator of the DAPA-CKD study Professor Will has been involved with a lot of clinical practice guidance for several organizations, and he was co-chairing the KDIGO from between 2012 and 2019. Please, Professor Abdelki, the talk is for you.
Thank you very much, Dr. Assad. I'm going to share my screen. And I hope you can now see my presentation. Okay, thank you. So thank you very much for the invitation to speak. And this talk follows very logically from Dr. Tanner's talk, because I'm going to talk about what we can do when we actually find patients with chronic kidney disease. And Dr. Tanner talked about the two main classes of drug that I'm going to talk about, the ARBs and the SGLT2 inhibitors. I've got some disclosure mentioned in the bottom of the slide there. So I'm going to use a patient as an example for this presentation, and this is a fairly typical patient that would get referred to our renal service in North London in England. The 8-year-old man with type 2 diabetes, and he's had his type 2 diabetes for 10 years. He is overweight. He is on metformin twice a day, 500 milligrams. He's on glycoside twice a day, 40 milligrams. And he's on a statin, which is a good thing. That will reduce his cardiovascular risk. Now, he attends annually for review, so he is being screened. He's getting his screening done, and he comes up to his primary care physician in the local practice for his annual review. His blood pressure is measured, 155, and I would argue that's rather high. And he gets blood results and urine results, and the results come back a few days later. eGFR of 46, but a year ago that was 52, so he's losing eGFR over the year. He has a urinary albumin to creatinine ratio of 76 milligram per millimole. Now, some people use units that are in gram, and that would be 10 times this level, so 700 milligram per gram. But again, this has gone up. It was 35 a year ago, so this has doubled. And his diabetes isn't well controlled. His HbA1c is 72 millimole per mole, or 8.7 in the percentage units. So this man is in trouble. He's far, and he's developing worsening albuminuria. Now, we think he's probably got diabetic nephropathy, and there's some clues. In this case, he's had long exposure to diabetes, 10 years. He has actually got retinopathy, and you can see a picture of a retina here from a patient with diabetes disease showing those soft exudates at the back of the eye, which are sort of the optical equivalent of albuminuria in the kidney. This is albumin leak into the tissues. And he's got albuminuria, which is a classic feature of diabetic kidney disease. So we don't probably need to do a kidney biopsy in this case. I've got a biopsy there from a patient with diabetic kidney disease showing these nodules replacing the normal tissue in the glomerulus. But we don't normally biopsy these patients. We normally assume this is diabetic kidney disease and we treat them accordingly. Now, Dr. Tanner mentioned ACEs and ARBs, and these are medicines that this man should certainly be on. And these are the two trials that were done 20 years ago now in patients like our man with the combination of type 2 diabetes and kidney disease, what we call diabetic kidney disease. And both of these trials showed a benefit of adding in an angiotensin receptor blocker. The trial on the left, the RENAL trial, used losartan. The trial on the right, the IDNT study, used irbesartan. Both were compared to placebo. The axis in these graphs looks at the proportion of patients developing ESRD, or end-stage renal disease, meaning that they have an eGFR of less than 15 or require dialysis. And you can see here that in both of these trials, randomizing to the active drug reduced reaching end-stage kidney disease. You can also see that there's a large residual risk. We do not solve this problem. You still see patients, even on these drugs, who reach end-stage kidney disease. But we did, in these trials, reduce the risk by around about 20% or so. So patients with diabetes, with albumin in their urine, should be on an ACE or an ARB. And we do now know from further studies that ACE inhibitors are as effective as angiotensin receptor blockers. ACE inhibitors in my part of the world, in London, because they're actually cheaper. We're actually going to put this man on irbesartan, an ARB. I wasn't looking after him. One of my colleagues put him on an ARB. He's on irbesartan, 75 milligrams, and we are increasing that to 300 milligrams, which is the maximum dose. And by doing that, not only will we reduce his blood pressure, but we will also protect his kidneys from further damage. So we have initiated here kidney protection by putting him on an ACE or an ARB. Showed the irbesartan was better actually than which was used as a comparator. So both drugs reduced blood pressure, but it was the irbesartan that actually improved the kidney outcome more than the amlodipine did. The amlodipine, the number of end-stage kidney disease events in those who were on amlodipine was actually similar to placebo. So there's something special about these drugs. We must get patients onto them. Now, this man would also be eligible now for an SGLT inhibitor. These are the gliflozin drugs, the ones here that we have available in my country, but these may vary in different countries around the world. And some of them now are becoming available as generic, and of course that will bring the price down dramatically for these agents. These were designed to treat people with diabetes, and what they do is they cause a leakage of glucose through the kidneys. They stop reabsorption of glucose in the proximal tubule of the kidney, and they cause patients to leak out that sugar in their urine. And the thinking was that if patients leaked out the sugar in their urine, they actually would, their diabetic control would improve. They wouldn't need as much insulin or diabetes drugs, because as they lose sugar in the urine, they're losing calories, they may lose some weight. And because these drugs are blocking a sodium glucose cotransporter, that's what the SG stands for, sodium glucose cotransporter 2. Because they're blocking a sodium glucose cotransporter, when you put patients on these drugs, they also leak sodium out into their urine, and that can lead to a reduction in their blood pressure, and that will obviously be of value. And these drugs do all of these things. In patients with good kidney function, they reduce HbA1c, they can lead to a little bit of weight loss, a couple of kilograms, and they can reduce both systolic and diastolic blood pressure. Now, the surprise with these drugs was that they did more than this. And this early study, this is a study of canagliflozin, 1,450 patients who were already on metformin, and they were randomized to canagliflozin, either 100 or 300 milligrams, that's in the blue lines, or to glimepiride, which is a sulfonylurea, in the red line. Now, all of these drugs include glycemic control, but we're looking here at estimated GFR, so kidney function over the course of the study. So those patients who were started on the SGLT2 inhibitor canagliflozin actually showed a drop in their eGFR very early in the study. But then there was a leveling out and a stabilization of their kidney function from that point onwards. So an initial drop followed stabilization of their kidney function, as you can see here. So overall, these patients had better kidney function at the end of the trial compared to those randomized to glimepiride. Now, these drugs were not expected to do this, but this initial in EGFR suggests that these drugs are doing something useful. They're actually reducing the pressure in the kidney exactly the same as an ARBs do. So this initial drop in EGFR, which can be a bit alarming if you put patients onto these drugs and measure GFR a few days later, you might see a drop, but this is a drop in the pressure in the glomerulus, a reduction in EGFR, and in the longer term, this leads to kidney protection. Now, in the safety studies that these drugs went through, there were some clues that they had kidney protective benefits. And this is from the EMPA-REG study. This was on patients with diabetes at high risk of cardiovascular disease. This was mandated by the regulators who wanted to check on the safety of these compounds. And not only did these compounds prove to be safe from a cardiovascular, they actually had cardiovascular benefits. That's a topic for another day. But in this study, these drugs were shown to have kidney benefits. So the trial wasn't really designed to look at kidney disease, but the investigators collected some bloods and urines. And you can see here that in the EMPA-REG study, patients randomized to empagliflozin were less progression of their macroalbuminuria, less likely to double their creatinine, and were less likely to get RRT, renal replacement therapy, that is dialysis. And as I say, this was not really expected from the trial. So the kidney community got very excited about this, and nephrologists like myself helped in the development of randomized controlled trials in patients with kidney disease. So here you have studies of SGLT2 inhibitors in patients with kidney disease, some of whom have diabetes, and we'll come to this in a minute, but some of these patients in these trials. You can see here the trials have different inclusion criteria with different ranges of EGFR and different ranges of albuminuria. We're not going to worry too much about that. 3 trials in patients with kidney disease with different SGLT2 inhibitors. So let's go to the Credence study. And this was a trial that actually our patient, who I've already described, would have got into. In fact, he would have got into all 3 of these studies. This was a study in patients with type 2 diabetes, EGFRs between 30 and 90, and albuminuria. This would be 300 to 5,000. Kidney or cardiovascular causes. And you can see here in this Kaplan-Meier plot, a 30% reduction in the risk points in the participants in blue who were randomized to canagliflozin. So on top of the ACEs patients were on, they got added kidney protection from canagliflozin when compared to placebo. And not only that, if you look under the graph here, drugs reduced the risk of cardiovascular death and heart failure hospitalization, which was another composite outcome of the study, the risk of major adverse cardiac events, MACE, heart attacks, and strokes. So here's a drug that in the context of diabetic kidney disease reduces progression to needing dialysis and reduces cardiovascular risk. And that was good news for kidney patients. The second of these trials was the MEA CKD trial. Again, our patient would have got it. The difference with this study is that this study recruited non-diabetic patients. And the thinking at the time was that if these drugs reduce that pressure in the glomerulus, which we saw with that drop in EGFR, then they may well prevent who have non-diabetic kidney disease. So this study, patients with GFRs between 25 and 75 who had albuminuria, but they didn't have to have type 2 diabetes. The endpoint is a similar collection of kidney events and included cardiovascular death. And the results were really very similar to the Credence study. But what I've done here is I've separated out those who have diabetes on the left-hand side with those who do not have diabetes on the right-hand side. And you can see here, really no difference. We see kidney protection with these drugs, whether or not these patients have diabetes as an underlying diagnosis. So these are drugs for non-diabetic kidney disease as well, which is really exciting. The other exciting thing about this trial for us was that all-cause mortality as a secondary endpoint. And you can see here in the graph, in the box on the right, that randomization to dapagliflozin in this trial reduced the risk of all-cause mortality. And this is the first pharmacological agent that has been demonstrated to reduce all-cause mortality in patients with chronic kidney disease. So again, great news for patients. We can reduce their mortality rates by putting them onto dapagliflozin, this SGLT2 inhibitor. I'm just going back to eGFR again. This is the estimated GFR during the course of the study, and you'll see once again, let me emphasize it, this initial drop. When we start these patients on SGLT2 inhibitors, their eGFR, which we want to be better, will actually get worse at about 2 weeks. And that is because these drugs have lowered the pressure in the glomeruli in the kidney. The glomerular filtration's gone down, but the pressure in that glomerulus is now lower. That glomerulus is now protected. And if you look at what happens over the rest of the study, after that drop, these patients who are on or are randomized to dapagliflozin in blue show slower progression of their kidney disease. And just going back to Dr. Tanner's graphs, this would have been a patient in whom we'd intervened and slowed that rate of deterioration time, meaning this patient would not reach end-stage kidney disease, hopefully, at a stage in their life, or even not at all during their lifetime. So the final one of these trials is the EMPA kidney study. Again, similar, included patients with chronic kidney disease with and without type 2 diabetes. Slightly different inclusion criteria. Actually included patients who didn't have albuminuria, but had eGFRs between 20 and 45. Again, a similar collection of kidney outcomes, a very similar result to the other two trials. 3 drugs, 3 different trials, all showing that SGLT2 inhibitors lead to kidney protection. Now, what about those patients with albuminuria? This is a forest plot showing the benefit of the drug to the left-hand side of this line, and showing that in those patients who went into this trial with lower levels of albuminuria, we don't quite see the protection that we would expect in those with higher levels of albuminuria. So the message here is that these are drugs really for patients who have chronic albumin in their urine, and these are the patients you should target, at least initially, with these to improve their outcomes. Looking at the data, there's some suggestion that these patients with low or no albuminuria might benefit, but you have to look quite hard in the data to see that benefit. It's a small slowing of their eGFR decline. So I've shown you 3 trials out of 13 trials that have involved these drugs. Some were safety studies, or should we say cardiovascular outcome trials mandated by the regulators. We've had these kidney trials, and we've also had heart failure. And these drugs, as you know, I'm sure, have been shown to improve outcomes in patients with heart failure, whether the ejection fraction is reduced or whether the ejection fraction is preserved. So fantastic news, a drug that not only slows progression of kidney disease, also reduces heart failure outcomes, and of course, reduces HbA1c in most patients. So what are the safety issues? There's undoubtedly an increased risk of infection, particularly in the genital area, because of the sugar in the urine, and patients need to be sure that they are careful with their own personal hygiene to avoid this problem. As I mentioned earlier, these drugs have diuretic properties, and this can lead to fluid, and in vulnerable elderly patients, perhaps this can lead to dehydration, particularly if these patients are on other diuretics, particularly loop diuretics. So just be a bit careful in elderly patients, thinking about the possibility of dehydration when patients go onto these drugs. Now, I showed you that drop in EGFR, which is a reduction function, hugely reassured by the fact that these drugs do not increase the risk of acute injury or acute renal failure, as we used to call it. In fact, they do the opposite. In all I've shown you, these drugs reduce the likelihood of acute kidney injury. We haven't seen an obvious increase in the risk of urinary infections, although, of course, we are inducing glycosuria, which you might expect to increase sepsis in the urinary system. That's not been a big problem. We do see ketoacidosis in these trials in patients on this. It's a small increase in risk, but it's a real increase in risk, and we need to be aware of that. And these patients can present with normal blood sugars because they are weeing out the sugar. So just be aware of that. Ketoacidosis with a normal blood sugar, always check for ketones if these patients become sick. And don't use these drugs in type 1 diabetes because these patients are particularly prone to ketoacidosis when put onto SGLT2s. And finally, there's been a few concerns risk of leg amputation or foot amputation or toe amputation. It's probably a real signal from the trial, and we should just be a little careful of severe peripheral vascular disease. We can actually put this risk-benefit ratio together in a balance here, and this is actually from a meta-analysis. So this is a big analysis that takes into account the data from all those studies that I showed you in that timeline, 13 studies of SGLT2 inhibitors. And we can see here the benefit versus the harm. So if you look on the left-hand side, patients with diabetes, if you treat 1,000 patients for 1 year, you will prevent 11 kidney disease progression events, prevent 4 acute kidney injury events, and you will prevent 11 hospitalizations from heart failure. So you're going to prevent here 20, you're going to prevent 6 events in these patients by giving them these drugs. The downside is you're likely, if you treat 1,000 patients for 1 year, you're going to see 1 ketoacidosis event and 1 limb amputation event statistically. So there is a bit of an offset here with that lower risk. But I would argue that the benefit here hugely outweighs the risk. If you take patients without type 2 diabetes on the left-hand side, you'll see here actually you're preventing more kidney disease progression events in this population, not seeing that safety signal in those with CKD but without diabetes. So I'm coming to the end. We're going to add in an SGLT2 inhibitor in our patients' therapy. I'm going to be impartial here and suggest that could be canagliflozin 100 milligrams or dapagliflozin 10 milligrams, dapagliflozin 10 milligrams, whichever you prefer or whichever is available to you. And by doing that, we are adding in further kidney protection and making it less likely that this man progresses to kidney failure. So these are my take-home messages. Benefits with ACEs and ARBs and SGLT2 inhibitors when it comes to kidney protection. The evidence for benefit is more obvious in those who have albumin in their urine, so target those patients for kidney protective therapies. Get your patient onto the maximum tolerated dose or an ARB, not both, one or the other, and add in the SGLT2 inhibitor. You will see a drop in EGFR when you start these drugs. Don't worry about it unless it's massive, unless it's 40% or something ridiculous. But you are actually dropping that EGFR, demonstrating that you have done something useful in the kidney pressure. And don't use SGLT2s in type 1 diabetics. Let the experts in the clinics do that. And be careful in patients with peripheral vascular disease. Thank you very much for listening to me. That's the end of my presentation.
Really thank you, Professor Wheeler, for your excellent presentation, of course, of the studies and reviewing early studies in 2001. So thank you very much, Professor Wheeler. So I'm going to now see some questions was appearing on the from the audience. one of the questions. I'm still waiting for the translation because it's in French. It was directly for Professor Wheeler, but there's an interesting question from one of the attendees that the initial dip want to be cautious. That the slide that you have been shown to us, the acute kidney injury with the initial canagliflozin, and if you want to start an SGLT2 RAS inhibitor, when to start? I understand the question that do you mean that the SGLT2 inhibitor to start before or after the exact meaning? So, but this is a question that's written to me, sir. Incidence of hypoglycemia in non-diabetics, when you mentioned about the use of SGLT2 inhibitors in non-CKD patients. So, can you shortly answer these three questions, sir?
Yes, of course. The initial dip, if it's greater than 30 or 40%, then worry about that patient, suspend the SGLT2 inhibitor and arrange further investigations, including imaging of the renal artery, because this could be a patient with renal artery stenosis. When to start? I would maximize RAS blockade first and add in SGLT2 after. That's what we did in the trials. If the patient doesn't tolerate the RAS blockade because of hyperkalemia or cough or whatever, you can still use the SGLT2 inhibitor without the RAS blockade. And we have some data now to suggest that the SGLT2s work just as well, whether the RAS is there or not. But of course, you're adding to the kidney protection by adding the RAS and the SGLT2. But the SGLT2 will still offer kidney protection, we believe, even if the patient's not on the RAS. And no hypoglycemia in the non-diabetic patients on SGLT2 in the trial. In the trials, I should say, DAPA and EMPA, no hypoglycemia in diabetic patients.
I pretend that the answer was very clear to the question, to the attendee. And second, yes, you just answered the incidence of hypoglycemia. There was no incidence of hypoglycemia. I think, sir, you answered these questions also. Yes, you did. You did not mention that there is no increase in the incidence of hypoglycemia when used in non-diabetics.
I didn't say that in my presentation, but the data shows that in non-diabetics in the trial, there is no hypoglycemia. And that is logical. That is logical because these drugs work depending on the blood sugar. And if the blood sugar is low, these drugs effectively, stop working. The amount of glycosuria is directly proportional to the amount of glucose filtered and therefore the plasma sugar.
The second question by Mazhar Riley, and I think the answer to your questions, Mazhar, has been just answered by Professor Wheeler, that how soon can SGLT2 be started in patients who have been recently initiated on maximum dose of ACIRB, sir? Do you have a short answer for that?
Yeah, absolutely. It's a bit of a debate at present. It's probably worth leaving 4 weeks between maximizing the ACER and starting the SGLT2. I do have colleagues that are starting both drugs at the same time. It doesn't seem to be cool. I think as long as you're monitoring the patient and you've got a sensible patient, I think it's reasonable to perhaps leave a gap of 2 to 4 weeks, but I would leave a gap between maximizing the ACE and starting the SGLT2.
Shall we have a time for taking another question?
We have more questions.
Yes. Another question from Henry. The question was, how can this apply in a pregnant woman, Professor Wheeler?
Well, as with virtually all trials of newer drugs, we don't offer these drugs to pregnant women until we know whether they have any effects on the fetus. So we have, in those trials I presented, no experience, and I don't think the companies have much in pregnant women. But these might be drugs that would be attractive in patients who develop diabetes during pregnancy, or in patients who are diabetic and go into pregnancy. But I cannot give any information on that source of the practice.
Is there any specific pathophysiology, sir? Is another question by one of the attendees. Any specific pathophysiology increasing that will explain the increased risk of amputation
No, so I
There's
can
no
see,
explanation,
yeah,
I
I
think,
can,
so
I can
yes.
see that's come from Ivan. We really cannot understand this. We can't understand this increased risk of amputation. And I think it's a great question. It's possible that these drugs increase blood viscosity because of their diuretic effect, and that the thicker blood, if you like, is more sticky and more likely to coagulate in diseased peripheral vessels. That's the most obvious, that's the only explanation we can come up with. We haven't found any other explanations.
There was some concern about the erythrocytosis that may cause with SGLT2 inhibitors with chronic use.
Yeah.
Another question, yes. Thanks, Professor David. That's for you, sir. At which point do you inhibit in non-diabetics, and what is the risk of recurrence of kidney disease when you withdraw the medication?
Yeah, it's a good question. We haven't withdrawn in a lot of patients, to be honest. We keep these drugs going even when patients get down to really low EGFRs. And in the trials, we had patients start dialysis whilst taking their study medication, so whilst taking an SGLT2 or placebo, and we found no evidence of harm giving these drugs patients who were on dialysis. So actually, we don't have a lot of EGFR at which we stop these drugs at the present time. We keep them going.
So are SGLT2 inhibitors are of benefit in end-stage kidney disease secondary to chronic GN?
Great question. We have experience down to an EGFR of 20. There's a study going on at present in patients with EGFRs between 20 and 18. It's difficult to understand how these drugs might work when kidney function is very, very, very low, because they work via the kidney. So if the kidneys aren't working, it's difficult to understand how the drugs will work. But we haven't found a lower limit to their benefit in the trials. We've looked right down. We have patients who go into the trials with an EGFR of 20. They drop their EGFR during the trial down to 15. They still seem to show benefit compared to a placebo patient with similar levels of EGFR. So we don't really have a lower limit at which to stop.
So another, I think, question. The dose for DAPA to start, sir, the dose for DAPA to start for non-diabetic CKD patient.
10 milligrams?
Yes, CKD stage 3A initially should be ideally how much? Patient also is on valsartan.
Yeah, 10 milligrams for everybody. There is a 5 milligram dose. It's getting harder to get hold of. We had the option of dropping to 5 milligrams in the trial. No patients dropped to 5 milligrams in the trial that I can remember. It's 10 milligrams for everybody.
Yes. Just do some nephrologists, sir, prefer to start for the first few weeks with 5 and then to get up to 10 milligram after a few? Yeah, there is some trend of some nephrologists to start with 5 milligram for a few weeks and then to get up to 10. Okay, so in patients with a lower GFR less than 20, are the AC inhibitors or ARBs are still in?
Absolutely. We actually did a study recently in the UK where we did an ARBs when patients got down to that level of EGFR to see whether we could get back a bit of their kidney function, recover the kidney function that was lost when the drugs were started, and keep these patients off dialysis. And that strategy worked. And there was a suggestion of an increased cardiovascular signal, as you would expect when you stop these drugs. So don't stop ACEs and ARBs in patients with low EGFRs or SGLT2s. Continue the drugs.
Yes. I think in a diabetic, sir, with no hypertension, can SGLT2 be added to a third line following metformin and sulfonylurea?
Yeah, absolutely. So added into other, remember that when GFR drops below around about 40, these drugs are not effective at lowering blood sugar. So when EGFRs drop below 40, the only reason you're giving these drugs is for kidney protection. They don't drop blood sugar usefully. So you will need other agents to control diabetes with more advanced CKD, and GLP-1s are a good option.
So I skipped one of the questions about type 1, but there is another question after that. answer will be to both of them, sir. What about the use of type 1, yeah, type 1, 2? What are the precautions, and what do you should answer the question, sir?
Yeah, so the risk is ketoacidosis. These patients were not included really in those trials, or were not intentionally included in those trials. I think this is something that diabetic specialists can do, but that we as nephrologists and primary care physicians should not be doing because of the risks. So these are not drugs designed for type 1 diabetes.
So another question, sir. Shall we reduce the dose of insulin before starting SGLT2 inhibitor therapy?
Yeah, it's a good point. If you're worried about hypoglycemia, then you can do that. And the patients who did become hypoglycemic in the trials were on other glucose-lowering agents. So you've got to think about that. But remember, if the eGFR is below 40, the drug is not really going to lower blood sugars. But in those with better kidney function, yes, you might want to reduce insulin dose when you start these drugs to prevent a low blood sugar.
Another question, I think it's an interesting one, that do I worry if I see too much glucose in the dipstick examination of patient therapy?
You know, it really catches people out
Yeah.
because these patients have glycosuria, and you think sugar is poorly controlled, but it's not. They are leaking sugar. So it's worth making the patient aware that if a healthcare professional checks for sugar in their urine, they should have sugar in their urine because they're on the drug. And that it's actually a test of compliance. If they've got sugar in their urine, they're probably taking the drug, or they've got a very high blood sugar.
Now the questions changed its character, going for the basics. Is ACE inhibitors the first line of treatment?
Yeah, well, ACEs or ARBs, whichever you prefer, doesn't matter. They're both equally effective at kidney protection in head-to-head comparisons.
Do those medications, whether ACE or ARB, are recommended for CKD and early stage without hypertension?
Yep, we absolutely, we're giving these drugs for kidney protection. We don't mind what the blood pressure is. The reason to give the drug is to protect the kidney. So the only time when you can't give the drug is if the blood pressure is too low and the patient is dizzy. But we're not using these drugs only to treat blood pressure. We're using these drugs to protect kidney function.
So GFR, exactly we start, and what you use the SGLT2 inhibitor? The answers in the trial. So yes, please, sir.
Well, the lowest that the trials went was mil per minute. Yeah. That's the lowest the trials went. That was the EMPA kidney study. But as I say, patients in the trials dropped below 20 during the trials, and there were no problems even when the eGFRs dropped below 20 in the trials.
What's the lowest estimated GFR for ACR use? Well,
we start ACEs and ARBs at any level of GFR, right down to 15, 14 or below. We give our patients, particularly if they're diabetic, onto ACEs and ARBs, and we keep them on ACEs and ARBs when they start on the dialysis program or get their transplant.
Hamada has been put a question, but I think that the T is wrong. He means maximum dose of DAPA and not data. Could it be 20 milligram or more? Yes. It's written data, but I think the question is DAPA.
We have no experience in the trials with 20 milligrams, so I would be careful. I don't know what the risk to benefit ratio is with a 20 milligram dose. We used 10. We didn't see any reason to go above 10. We saw clear benefits at 10. I would use 10 milligrams.
A question from Yanga. It's a question that, in short, that the acute dip that happens with the SGLT2 inhibitors. You mentioned in your slides that the GFR will be protected after that, even after the initial dip. Does it to the initial GFR or become better?
No, it doesn't return to the initial GFR unless you stop the drug. And we have in some of the trials, at the end of the trial, the SGLT2 inhibitor has been stopped and the eGFR rechecked, and it does actually go back up. You regain what you lost at the start. But no, I mean, initial dip, you start at a new level. You start at a new GFR trajectory for your chronic decline of kidney function. You will start lower, but slope will not be so steep.
So another question, Zahra Khalifa. It's he's asking, of course, you, sir, that can you talk about cystatin C in a short period? First, second, it is enough to ask for routine serum creatinine and follow-up in the primary care settings, or we should ask for an estimated GFR or urinary albumin creatinine ratio to reflect the kidney function.
Well, in my practice, we can't get a cystatin C measurement. The laboratories will not do one. The guidance in the UK suggests statin may be useful in patients with eGFRs between 50 and 70, where you want perhaps a more accurate measure to see whether they're above 60 or below 60. But we do not use cystatin C routinely. To diagnose kidney disease, you need a creatinine that gives you the eGFR, and you need an albumin to creatinine ratio. That's all you need. You don't need anything else.
Dr. Tanner, can you give us your opinion also, because you have 2 slides about cystatin C? Are you with us, sir? Dr. Tanner?
I am here. Yes. So
yes,
it's actually exciting that Prof. Wheeler is saying that he doesn't use statins. So for we actually don't even consider it. But nonetheless, like he said, it's still very effective. We still know there are challenges with creatinine, but in my opinion, it's still the best we have, and it's very cost effective. In my opinion, you don't necessarily have to force your labs to get you cystatin C to be able to know how the kidney functions are doing. I think creatinine is still, in my opinion, an excellent marker of kidney function. Yeah.
Okay. Thank you, Dr. Tanner. I will turn back to you for the next questions, and this question is for Professor Wheeler, because the slide was containing all the side effects that probably will occur. That eoglycemic DKA, Sir Professor Wheeler, eoglycemic DKA. Is that a real, very interesting question? Yeah, the answer in short, please, sir, for this question.
Is it real? Is that the question?
Yes. Is it real?
Well, yes, it happens. It happens. It happened in the trials in patients who were taking other glucose-lowering agents as well. It happens in real life. We've had some reports in our British Medical Journal of patients who have come into A&E with a normal blood sugar, but they're sick. The ketones are not measured, and nobody picks up the ketoacidosis until the next day. So it's very important, if you've got a patient on an SGLT2 inhibitor, well, to think about ketoacidosis and to check for ketones. We sometimes, for the type 1 diabetics, I think the diabetologists sometimes give them sticks to check their urine for ketones, so that the patient can pick this up if it happens.
Professor Tanner,
it confuses the junior.
Yes. Dr. Tanner, the question is for you. The role of aldactone in stage 3A CKD.
Yes, so indeed, I think the non-steroidal mineralocorticoid receptor antagonists are the ones that currently are coming up so strongly. I mean, in terms of prevention of progression. But nonetheless, our good old spironolactone is still a good drug. More especially, I've come to realize in my practice, if you probably are thinking about a secondary hyperaldosteronism, I mean, you have a young patient, uncontrolled blood pressure. So we think that it definitely has a major part to play. The only caveat, of course, and that is why you are pulling it off, is hyperkalemia, right? So in as much as you're able to manage your potassium, it's such a valuable medication to use. But nonetheless, it's not been shown much progression, but rather the non-steroidal mineralocorticoid antagonist. Yeah.
Thank you, Dr. Tanner. Professor Wheeler, do you worry about the blood pressure with SGLT2 inhibitor therapy? For example, in heart failure patients with a systolic blood pressure of about 90, 100 millimeter mercury, do you need to worry about the blood pressure when you initiate a SGLT2 inhibitor therapy?
Well, I think our cardiologists would worry if the patient became symptomatic. It's a small reduction in blood pressure. It's about 4 millimeters systolic. It's a small reduction. And I think as long as the patient can tolerate that slightly lower blood pressure, again, the benefits of giving the treatment far outweigh, the risks. But if you've got a vulnerable patient who's likely with a low blood pressure, then yes, of course, you should be careful, as you would be with ACEs and ARBs and other treatments you would give for heart failure.
So sometimes I'm translating the questions with some flavor. Do you think that the SGLT inhibitor therapy will work in the future for a lower than 20 ml of GFR?
As I said, Elliot, I'm very happy for you to answer any of these.
So I think it's tricky. I think Prof. Wheeler mentioned, which I think is also what I think, that generally the medication works with a good functioning kidney. So in as much as GFR has gone to some level, then we probably don't believe that it will be able to do that which we hope it will do. And again, most of the studies hardly go beyond 20, so below 20. So whatever we say below 20 is just, practice and what we hope for. We don't have hard evidence for below 20. As to what will happen, I don't know. I think we get more excited as we see things to try and, okay, I'm sure some study will come and say, let's look at between 20 and 10 or 20 and 5 or something. But I'm afraid we might not be able to pick that good difference that we picked, with the higher GFRs. That is my opinion. Prof. Wheeler can add on.
And there is a study in the Netherlands that will hopefully address this question, but we won't get data for 3 or 4 years.
Okay, Professor Wheeler, one of the questions that should I continue on metformin with declining kidney function during initiating SGLT2 inhibitor therapy?
Yeah, I saw that question, and I think that was the question that was put in French earlier on. So we say
Professor Wheeler,
if EGFR drops below 30, you should discontinue metformin because of the risk of lactic acidosis. There's a bit of debate, and some of our diabetic colleagues will continue the drug because they say it's so good and the risk is so small. But I think it's probably not safe practice to carry on in the current environment with the guidelines as they are.
Yeah, so maybe just to just make a point on that, indeed. So I probably am one of the nephrologists who tend to side with the diabetologist in this. Metformin is such a good drug, and indeed, from where I practice, our options in terms of glycemic control are not much. So what I actually see a lot of primary care physicians, they read the guidelines, is the fact that a patient who is probably on metformin, doing so well, bicarbonates are good, no worries for lactic acidosis, will switch from metformin to, let's say, a sulfonylurea or probably some insulin, and the next 2 weeks the patient is on admission for hypoglycemia. So it's really tricky dependent on a setting. And again, we don't have stringent where we are stringent, FDA in terms of the moment, somebody chasing you as a physician, that the moment they're below 30, probably stop the patient. So some of us are a bit liberal, and because again, metformin is a good drug, and people believe that lactic acidosis probably is a myth, in terms of the doses that we give. So I think it's individualizing your patient and monitoring the patient is always key. But I've had situations where I've had to push it up a bit. Yeah.
Thank you, our doctors, but I will take another 2 questions because of the shortage of the time, but they are interesting because it's a new idea. One of them for Professor Wheeler, do you continue your SGLT2 inhibitor therapy in hemo or peritoneal dialysis patients?
Yeah, I mean, that's what happened in the trials, or some of the trials. We had patients in the DAPA CKD study who continued study medication despite starting dialysis. The difficult thing is to understand how the drugs might benefit them if the kidneys are not working. Perhaps they will protect their residual kidney function, which is still very useful on dialysis. perhaps they will still work to improve cardiovascular outcomes. I don't know, but these drugs work in the kidney, and when the kidneys aren't working, it's difficult to understand how the drugs would work. So I would not see this as a priority. But there's, as I say, from the safety perspective, we didn't see any big problem continuing these drugs in patients starting dialysis in the trials.
Yes, but there was some Spanish evidence about 17 or 22 patients who have continued on SGLT2, and there was no reported side effects in the Spanish data.
Yeah.
So the last is for, and shortly, please, what is the case for transplantation?
In terms of SGLT2?
Yeah.
Okay. I think, I mean, from my experience, I'll probably speak from my experience more, in the sense that more often than not, we run into trouble. I mean, I'm sure Prof. Wheeler will be able to answer this better. We run into trouble in terms of sustenance of our SGLT2s, even in spaces or in patients where probably we think there's benefit. Obviously, by the time they get onto dialysis, so I don't have any of my patients, even on SGLT2, even on dialysis, even to talk about, considering what is going to happen post-transplant when they decide to get it. So I think Prof. Wheeler would take this one. Yeah.
Yeah, I mean, we don't have data from trials. We have data from observational studies. We do not know what the risk to benefit balance is, but my colleagues are starting patients who've had kidney transplants on these drugs, partly to treat their diabetes, but also in the hope that they may preserve their graft function. So we haven't got good data from trials. It's happening in practice. We'll see whether any problem, I guess, in routine practice.
Yes, I think the data are only localized for centers and personal experience about the use of SGLT2. Yes, thank you a lot for the very interesting answers of our speakers to the questions. And now we move to the next session. Professor Abdullah Al-Maliki. He's assistant professor of medicine and nephrology in King Saud bin Abdul Aziz University, and he's head of nephrology, consultant nephrology and kidney transplant, King Abdul Aziz Medical City. He's a director of nephrology fellowship program in the Western region, Jeddah Nephrology Club, and he's qualified for fellowship in nephrology and kidney transplantation, and he's a fellow of the ISN and grad certificate program in clinical epidemiology, Western Ontario, Canada, and he has a master in medical education at Saud bin Abdul Aziz University of Health Sciences. Welcome, Professor Abdullah, and we are ready to hear your talk.
Thank you, Mr. Chairman, and thank you for the invitation to present my talk. So the title of my presentation will be Driving Chronic Kidney Disease Guidelines Adoption, the KD. So we have already learned from previous talks about the burden of chronic kidney disease and the challenges with the screening and to the guidelines with the early detection of chronic kidney disease, and then also from the larger clinical trials on inhibitor. And now we will move to the effect of these clinical trials and their finding on the evolution of clinical trials, especially latest addition to the trials with SGLT2 inhibitors. As we have seen this slide, worldwide we have more than 800 million people with chronic kidney disease. So the risk is something like 10 to 13% in any population, and is much higher in patients who are at higher risk, like 3 times higher in patients who have cardiovascular disease or patients who have diabetes, and is higher in patients who have hypertension. And we expect this to increase in the future, as well as the cost of the disease also increases. Now, just to remind the audience, we risk stratify our patients with chronic kidney disease based on the eGFR and the albuminuria. So stage 3 disease, which is definition for chronic kidney disease, that is less than 60 down to 30, and 18 to 29, that's stage 4, 15. And we use the urine issue or albumin, creatinine, and we use the milligram per gram. So less than 30, this is normal to mildly increase albuminuria. 30 to 300 is moderately increased albuminuria, which we used to call it microalbuminuria. More than 300 is severely increased albuminuria. Now, we have seen the clinical trials with Professor Wheeler, and I here only mention the 3 main large trials that have impact on the guidelines, have the highest impact on the guidelines: the Credence trial, the DABA CKD, and the IMPA kidney. And the good thing about these trials, especially the last 2, they have included not only diabetic patients. So the Credence was on the canagliflozin, DABA CKD about dapagliflozin, and we have the IMPA for both diabetic and non-diabetic patients. And with the DABA CKD, it has a renal protective effect. It reduces the primary composite endpoint, renal endpoint, by about 39% relative risk reduction, with a number needed to treat of 19. And same thing is also noted with empagliflozin. So you have a reduction in the endpoint by relative risk of 28%, with number needed to treat of 27. And also we see the same thing with Credence with canagliflozin among diabetic patients, 30% relative risk reduction, with a number needed to treat of 24. The mortality data was more evident for the DAPA CKD, with reduction in mortality, all-cause mortality. That was the only one among these studies was a statistically significant finding, with a number needed to treat of 48. And this is a duration of follow-up of around 2.5 years. Now we have the 2023 KDIGO clinical practice guidelines for the evaluation and management of chronic kidney disease as a public review. It was also presented in the ERA this year. Guidelines for the RAS inhibition change, and for the last more than 2 decades now, RAS inhibition remained the cornerstone of management of patients with chronic kidney disease, with and without diabetes, with the specific recommendations. So this is for the chronic kidney disease, not for the diabetes, to include diabetic. So the recommendation for, if you look here, green bar, and I put a red bar. The green bar are patients with no diabetes, bar for with diabetes. So RAS inhibition is the first-line treatment of patients with chronic kidney disease, even among non-diabetic patients, if they have hypertension and severely increased albuminuria. Also, with moderately increased albuminuria, the evidence is not very strong if in the absence of diabetes. It's the highest level for the RASI, which is level or a grade 1B. Grading the evidence, the recommendation is graded as 1 and 2. 1 is a strong recommendation, and that's the term when we say we recommend. And 2 goes for that is a less robust evidence based on the effect size. So the recommendation becomes suggest. So the clear benefit and harm is less observed as compared to the level 1.
Professor Abdullah.
Yeah.
Excuse me, if you can raise your voice and go closer to the mic, this will be great to ensure all audience can hear you well.
Sure, thank you. For patients with diabetes, they are recommended to be started on RAS inhibition if they have high blood pressure, chronic kidney disease, and moderately increased albuminuria or higher. So a level of proteinuria is an indication for RAS use among diabetic patients. And it's not recommended to combine ACE or ARB or actinium inhibitor, not recommended to combine 2 of them. Now, SGLT2 inhibitor, as of the most recent guidelines, the recommendation for non-diabetic patients, sorry, for diabetic patient first. So any diabetic patients with chronic kidney disease, whatever is the level of albuminuria, is recommended to be started on SGLT2 inhibitor, as eGFR is 20 and above. And this is the highest level, even higher level the RAS inhibition. It's graded 1A. And once it's initiated, and that can answer the questions, some of the questions in the previous talk, it's continue even if the eGFR fall below 20, it cannot tolerate, or the patient was initiated on renal replacement therapy. It's also reasonable to withhold SGLT2 inhibitor at the time of prolonged fasting, surgery, or critical illness to prevent the development of ketoacidosis. For patients, the SGLT2 inhibitors are recommended if the patient is having chronic kidney disease, whatever is the level of albuminuria, in the presence of heart failure, or chronic kidney disease in the presence of albuminuria that is more than 200 milligram per gram. And if you look at the last one, it is suggested to start patient on SGLT2 inhibitor with a lower level of evidence if they have chronic kidney disease and they have moderately or part of the moderately increased albuminuria less than 200 milligram per gram, if they have more worse drop in eGFR that is less than 45 down to 20. So that's an extension for the inclusion or the initiation of SGLT2 inhibitor to patients who are not diabetic and patients who have also low level of albuminuria. This is the algorithm suggested by the KDIGO, and the algorithm shows similar to the diabetes, just there is no metformin. SGLT2 inhibitor here, you can see it as the first line with the RAS inhibition for patients with the indication that we have mentioned. This is the same recommendation. So patient with chronic kidney disease and heart failure, or patient with chronic kidney disease but eGFR more than 20 who have albuminuria more than 200 milligram per gram, it's also level 1A, which is the highest level of evidence of recommendation. And also we said that if you have CKD with lower eGFR, even with less albuminuria, SGLT2 inhibitors are suggested if the eGFR between 20 and 45. And remember this, a person with chronic kidney disease and heart failure, as we have seen, they have a clear indication for use of SGLT2 inhibitor to reduce the risk of cardiovascular death or hospitalization for heart failure, irrespective of the level of albuminuria. This is a meta-analysis for the major trials that I have mentioned, SCORE trial for both the diabetes and the non-diabetic, and it shows consistent benefit in the renal outcomes. Here, they talk about kidney failure defined by eGFR less than 15 or requirement of dialysis. With chronic diseases was published last year, and the emphasis was there's no change. Comprehensive care of people with type 2 diabetes and chronic kidney disease require foundation of both lifestyle therapy and pharmacological. And among the pharmacological therapy, the SGLT2 inhibitor are the foundation of treatment along with the RAS inhibition. And we also have recommendation on the use of the non-steroidal patient with albuminuria, even moderately increased albuminuria, despite maximum use of RAS inhibition if they have EGF25. This style modification or recommendations for all patients, and you can see the first-line therapy for diabetic patient, almost the same as we talk about the patient. So SGLT2 inhibitor and metformin are first-line therapy, and commonly diabetic patients as nephrologists when they are already on SGLT2 inhibitor. This is a report from both ADA and KDIGO guidelines, the same concept. So the recommendation goes for the annual screening, and we use both. We have to use both. So we screen for the function through the eGFR, and we screen also for the damage through the albuminuria. And we use the urine albumin creatinine ratio. And for the eGFR, and I heard some of the questions about the system and the creatinine, we use either of them or both of them. It's both of them. If you have it in your facility, because there are some reports showing that there is some discrepancy. You can diagnose more CKD with one test and will be above 60, EGFR above 60 with the other test. So both of them can disagree, and therefore to have optimal use of or diagnosis, the best diagnosis is actually to combine both of them. However, depending on what you have in your facility, I think most people use creatinine-based EGFR. Once we diagnose chronic kidney disease, which is a 3 months sustained drop in EGFR or albuminuria, that's a definition for the CKD, then we have to risk stratify our patient. We classify them based on the table that we have seen before, based on the EGFR and the albuminuria level. And then we have to devise a comprehensive plan that has a lifestyle modification and evidence-based pharmacological therapy. This was like last year. So we have seen this one. I don't need to spend more time on it. Now, the NICE guidelines have actually gone into the options of the management. And, you know, it doesn't matter which guideline you use, but you have to really be careful about the way the levels are graded in the guidelines. Most of the guideline bodies more the KDIGO guidelines is one of the most common we use in our practice. The NICE guidelines went to the licenses of as well as on the data, and they went to the options of treatment. If you have a patient who have chronic kidney disease, heart failure, and type 2 diabetes, it depends on how many of these abnormalities you have. So patients with type 2 diabetes, gliflozin are used. Heart failure, then or heart failure alone, dapagliflozin is used. In the presence of CKD with or without other disorder, then dapagliflozin becomes a priority. And you can look at this from the rows. If you look at the rows, the first one, type 2 diabetes. So in type 2 diabetes, if it's with heart failure, then DAPA or EMPA as recommended. If it's coronary artery disease, then EMPA or DAPA again recommended. But if there is CKD, whether with increased albuminuria, which is with 1 star, or moderately increased lower level albumin, which is the one with 2 star, then DAPA becomes a priority. If you have heart failure, again, with the CKD, DAPA becomes a priority. If there is no CKD, you go for either medication, and the same thing applies for coronary artery disease, except for coronary artery disease, there is no sufficient evidence to support SGLT2 inhibitor in coronary artery disease if they have less than 200 milligrams proteinuria. Now I'll take you back 2 years earlier when we have the release of the KDIGO early identification and intervention in CKD consensus. Now, persons with high risk, that's the recommendation, high risk patients for chronic kidney disease. The top 3 risk factors are hypertension, cardiovascular disease. However, this can be extended to other risk factors. These for chronic kidney disease. And you know, diabetes probably account for maybe 60% or more of all patients at risk of developing chronic kidney disease. CKD screening and treatment programs should be implemented in other high-risk individuals, as I mentioned. Items CKD are necessary to utilize treatment effectively, and that we have a good rationale. We have several medications now available for early use, and SGLT2 inhibitor are recommended as first-line therapy with metformin in patients with type 2, and they are also of benefit in patients with albuminuria, even without diabetes. So this slide just take you through the steps in the management from primary care physicians. So conditions that increase the risk of cardiovascular disease, we mentioned the top 3: hypertension, diabetes, and cardiovascular disease. But also there are others like AKI or prior hospitalization, family history of disease, obesity, older age, certain ethnic groups. So we consider screening for this, and screening goes annual, and we use both albuminuria and EGFR. And if it is normal, it goes. If it is present, we have to confirm it. A person we identify patient or label patient that chronic kidney disease, risk stratify our patient, and then we devise our management plan that goes from preventive strategies or patient safety, avoidance of nephrotoxic agents or any other that could be worsening, like dehydration. We go to slowing progression of the disease and protecting patient. So step one, identify risk group. Step two is to test patients, screening patients. And then step three is to diagnose and then stratify your patients. And you have the low risk patient who have normal increased albuminuria with eGFR that is above 60. There is no need to treat these patients, and you continue just annual screening. And for patients who are having albuminuria, moderately increased albuminuria, actually 60 to 90 with normal albuminuria but reduced eGFR, then we diagnose these patients moderately increased risk, and you have the high risk patient in the deeper yellow, and you have the red color for the very high risk. Also, the kidney failure risk equation for these patients to risk stratify the patients, and then even can help you in referral of these patients to a specialist. Now, the management approach is better handled in a multi-stakeholder implementation strategy, and that will include healthcare worker, include healthcare systems, patients, and professional societies and disease-specific bodies, programs like education and public awareness, and healthcare system integration program between the primary care physician and the nephrologist and the cardiologist do also improve the care of these patients. And the multidisciplinary collaborative plan is usually mentioned in different ways in the literature. You can see team-based care or collaborative care or multidisciplinary plans for these patients that can involve 2 people or up to 8 different disciplines, from primary care, nephrologists, pharmacists, healthcare assistant, trained nurses, and peer supporters and community workers. And the main goal is ongoing support to promote the self-care of the patient through education of the patient, increasing awareness, the use of organ protective drugs like RAS inhibitors and SGLT2 inhibitors, and the treatment to the goals and achievement of the goals with A1C and with blood pressure, as well as with proteinuria reduction and reduction in the chronic kidney disease progression. The effect of the team-based care or multidisciplinary care on all-cause mortality had been demonstrated in previous studies. There was one meta-analysis including multidisciplinary care mortality among patients with chronic kidney disease. There was significant reduction of the also significant delay in the onset to dialysis, and significant lower risk of need for temporary catheters for dialysis, and it was cost effective to apply. Now I want to share with you some of the local data that we have not published yet. We have done a study on patients with type 2 diabetes attending nephrology clinics, and we looked at the pattern of care in terms of early management of chronic kidney disease and also screening. We included 1,000 plus patients with type 2 diabetes attending primary care clinic, GIM, and endocrine clinics. As you can see, the first column, there was the average age or the mean age was 62. There was a prevalence of cardiac disease, 14% among patients with type 2 diabetes, not labeled with chronic kidney disease. 73% of patients having hypertension and 55% having a body mass index more than 30. The screening for eGFR was universal, 100%. Screening for albuminuria was suboptimal. Only half of these patients were screened. And reduced eGFR less than 60 was 10% among these patients. Screening for monitoring A1C annually, 55% of patients, and the level of A1C was a mean A1C level of 7.9, with A1C that is less than 8 or 8 in about 60% of patients. If you compare screened versus non-screened patients, there is more chance to be screened if you are attending primary care physician, and there is more prevalence of hypertension, cardiac disease, and CKD or reduced eGFR among patients who are attending who are not screened. The screening for albuminuria, only 49% of patients get screening for albuminuria, and for 18 months, even not 1 year. And actually, we did a randomly selected good number of patients to look for ordering the test, not only the test. And it was the fact that most of these patients, they do not have the test being ordered. So there is a low rate of adherence to the guidelines, only 50%. And that actually compared to the international figures, 30 up to 70, 80. In our institution, primary screening rate was much better, 80%, but still there is 20% are not screened. Center the clinics in the general medicine as well as in the rate was much lower, 36%. The RAS use in patients with albumin almost 80%, not very bad, but still 80% of patients they require this treatment.
Please, I want to be optimistic in time. Please, can you end?
I'm almost done.
Yeah. Thank you. Okay, thank you.
When we looked at the factors that lead to screening versus no screening, the only factor was actually the care setting, which may not apply to others, but that could be related to the better access to care, to the primary care, and the awareness probably is important. Patient and healthcare professional will have better integration and collaboration with the primary care physician than with other entities. In conclusion, guideline recommendations, systematic reviews of relevant studies and appraisal of the quality of evidence and the strength followed by the grade, following the grade approach. CKD screening coupled with risk stratification and should be implemented, and that this should be in primary or setting with context. And the success of CKD screening and treatment relies on involvement multidisciplinary care plan, and as we have seen, this model decreases mortality, delays the onset of dialysis, and is cost effective across a wide range of patient profile. Thank you.
Thank you, Professor Abdullah, for your nice talk. We will continue with our last speaker. I think you will share your slides. Presentation. Yes, the last speaker will be Dr. Amr Khalifa Hussein. He's a lecturer of internal medicine and nephrology, Kafr Sheikh University, Egypt, and he's a medical director at Kafr Sheikh University. He's had a PhD degree in internal medicine and nephrology at Israel University. Professor Amr, please.
First of all, I would thank you all, my colleague who paved the way to start my clinical implication of the new guidelines for management of CKD, to share my presentation. But first, I will give the audience about 1 to 2 minutes to scan this QR code and help me to solve the case. Only 1 to 2 minutes.
Open link.
هو the link as well is on the chat. فدونت worry
Yes,
دكتور عمرو.
it is working now.
وإيفنتي team added it on the chat as well.
Okay. Now, if we check the result regarding the Mr. Tariq case, most of the answers regarding the physical examination, most of the answers regarding inspection of the skin, the lab, most of the case check bicarbonate level more than ACR and calcium level of these patients. Radiology, about 61% of the audience choose to do ultrasound for our patient, and also for referral, refer to cardiology more than nephrology. And regarding the revise of the KDIGO guidelines, most of them choose to all of the above, which increase bicarbonate or add SGL2 inhibitor or management or blood pressure than 120/80 and uric acid less than 7. And then after initiation of dapagliflozin 10, which is the most reasonable action, most of them check monitor the GFR after weeks. Okay, I will back to my presentation. Let's meet Mr. Tari. He is a 63-year-old male patient, known hypertensive from non-diabetic. He is dyslipidemic. Body mass index is 28, blood pressure 150. He has family history of hypertensive chronic kidney disease. He is maintained on the maximum tolerated dose of telmisartan 80 and on rosuvastatin for management of his dyslipidemia. The lab investigation of Mr. Tariq, urinary ACR is 308, level 22, calcium level 8.5, albumin 3.8, phosphorus 4.5, and potassium is 5.1. According to last KDIGO 2023 guideline, which of the following intervention may have an effect on the progression of his chronic kidney disease over the next 3 years? In the question was blood pressure control less than 120/80 or uric acid reduction to less than 7, increase bicarbonate more than 22, or initiate SGL2 inhibitor, or all of the above. Most of the answer was all of the above, but I think the answer is D and not E. What is this? We have to know that the risk of mortality and end-stage renal disease is with the CKD progression. Whatever the cause of the CKD, either the patient is diabetic or not, with decline of the eGFR or of urinary ACR, the morbidity and mortality and risk for disease is increased. This is the recent innovation in the management of chronic kidney disease in the last 20 years. Only the who have proven protection for the kidney are the REN study for the ramipril or ident, renal, and roadmap. The combination between the ACE and ARB to add any benefit. Is that enough? For sure, no. The REN trial, which decreased the risk reduction for end-stage renal disease by 49%, still there is a huge residual risk. That means we are in need for further medication for management of the chronic kidney disease. When the dapagliflozin in the clinical trial, or either in the declared, have patients of higher GFR or the declared or the DAPA CKD to very low GFR, the primary endpoint or the second endpoint was relative risk reduction for the end stage for the kidney outcome was relatively increased in the DABA side. We have to always remember that 98% of the patients of the DABA was already on the maximum tolerated dose of ACE or ARBs, and 75% 3 CKD, and 74% was diabetic, ischemic, or hypertension, and 32 of this patient was without diabetes. That's why we take from this the evidence for management of the CKD by the SGLT2 inhibitor. What is the cardiorenal and mortality benefit of the DABA CKD? There is, for our patient, he is, don't have diabetes, 50 relative risk reduction for the patient. All-cause mortality decreased by 48%. The composite of cardiovascular death or heart failure decreased by 21%. For sure, this protection of the dapagliflozin regarding the diabetes status of the patient, either the patient is diabetic or not diabetic, it is protective. And all the DABA CKD, almost 98% of the two arms was in the maximum tolerated dose of ACE and ARBs. Don't forget, not only the hypertensive nephropathy, but add on IgA or FSGS, focal segmental glomerulosclerosis. There is relative action for use for the kidney disease, for favoring DABA in the management. Yes, we have to managing a chronic kidney disease patient. You have some instruction regarding the exercise, smoking cessation. All patients should have glycemic control, blood pressure control, lipid management, and most of the patients are indicated for RAS blockade and inhibitor, and some of them need antiplatelet therapy. What our patient is already on the maximum tolerated dose of telmisartan, and it is important for management of his hypertension state and for controlling the proteinuria. What we will add SGLT2 inhibitor, as the guideline recommended. Class 1A, we recommend treating adults with chronic kidney disease and heart failure with GFR 20 or more, with urine albumin creatinine ratio more than 20 milligram per gram, with an SGLT2 inhibitor. And even if the patient is not proteinuric, it is and have the GFR from 20 to 45 and CKD for sure, class 2B to use the SGLT2 inhibitor. This is important. When you combine the RAS blocker with SGLT2 inhibitor, you slow the progression of the chronic kidney disease, and you delay the end-stage renal disease by more than 15 years, which is so significant for our patients. The other pillar of our patient has serum bicarbonate 22. This patient is candidate for treatment of metabolic acidosis or not. The guidelines in people non-severe metabolic acidosis with CKD consider only dietary. If the bicarbonate is less than 16, you should treat. Monitor people with chronic kidney disease to ensure correction of serum bicarbonate doesn't result in concentrations exceeding the upper limit of normal, and doesn't adverse affect the blood pressure control. And this is important. If you prescribe more bicarbonate, you will have uncontrolled blood pressure. And if the bicarbonate is potassium based, you will have problem in the potassium management or fluid status. About the hyperuricemia, the KDIGO guidelines 2023, we recommend only treating the CKD patients hyperuricemic if only they are symptomatic, and this is class 1C. And do not recommend, we suggest using agent to lower the serum uric acid in people with chronic kidney disease and asymptomatic uricemia to delay the CKD progression, and this is class 2D. To wrap up, SGLT2 inhibitors are indicated for CKD patients, ACR more than 200, diabetic or heart failure patients. And don't forget, when you are dealing CKD patients on RAS blocker, don't forget the potassium management. And there is no data to support management of non-severe metabolic acidosis or asymptomatic hyperuricemia. And on top of them, the lifestyle, diet, and chronic kidney disease progression is observational. And thank you.
Thank you, Doctor, for your very interesting presentation. Dr. Amr, it was a very nice talk, and thanks. I think that all colleagues now are present now, and the floor is for any comments further from the speakers, just to consolidate our talk and give a good impression about what has been given today about the lectures. I think that the problem of early detection and what Professor Tanner said, the availability of more and more simple tests for the primary care physicians and probably for the senior house officers or even the residents, that these two tests are not invasive first, and secondly are cost effective. So screening the urine and a small volume of the blood to screen patients with type 2 diabetics for early kidney intervention. This is first. Second, there is just one notion, please. There was an answer that was translated from French, just to complete and to be fair with all the questions, because we answered all of them. And the question is that if there is any specific dietary management for patients with repeated ketoacidosis. I will answer Professor Wheeler, and you can give a comment after that. Eoglycemic diabetic ketoacidosis is not a problem of prescribing specific type of nutrition, but just avoid malnutrition patients. We want to avoid that those patients, if they are malnourished for any reason, for example, being sick for days or going to a major surgery, that we prefer to stop SGLT2 inhibitors before days for those patients. This is first. Second, if you want to anticipate patients going for an excessive exercise, for example, running for 5-6 kilometers or for a marathon, that we should advise those patients just to avoid SGLT2 inhibitors at least one day before, just not to push. There is no specific diet to avoid, and it is a complication that you can re-challenge with your SGLT2 inhibitor therapy when the patient is stable. I think the answer, Professor Wheeler, you can comment on that, whether there is a...
Yeah, I absolutely agree with the response. I answered this in the chat. I don't think there is a that prevents ketoacidosis. We, as you suggest that the patient spreads out their calories during the day. Of course, this is a problem when patients fast or want to fast for religious reasons, and you just have to be careful. But SGLT2 inhibitors are drugs that you would suspend in a situation where the patient is likely to be compromised, as you suggest, due to an operation or an injury or a marathon run or something like that. Absolutely agree.
Yes, I want just to comment of Dr. Amr's. There was a very interesting trial recently published about the addition of SGLT2 inhibitors over existing RAS therapy, and the conclusion of this trial was very interesting. It's just published, sir, that patients with SGLT2 inhibitor therapy, it seems that they can tolerate more ACE or IRB. And it was a very interesting conclusion that the blood pressure was not affected in this study. This is first. Second, patients with added SGLT2 inhibitor therapy in this interesting study was more tolerant to receive IC or IRB therapy. So the conclusion was the addition of SGLT2 over an IC or an IRB was more favorable for the patients. They would tolerate the IC and IRB, probably for the potassium, for example, or probably for the magnesium. I don't know exactly the answer, but the conclusion was very interesting, that the addition of SGLT2 was the patients was the profile was good. They were tolerating AC and ARB more.
Yes.
Yes.
The patients were less likely to stop the ACE or ARB during the
Yes,
trials
when
if
SGLT2
they
is
were on
added.
the SGLT2. And
Yes.
we know that if you look at potassium levels are lower in patients on SGLT2s in these trials compared to patients on placebos in these trials.
Yeah, on the discussion they mentioned that the serum potassium was more favorable when SGLT2 was added to initial ARB. Any other comments from the speakers? Please, I want to end our meeting today if there is nothing to add or to comment. Professor Wheeler?
No, sorry if I've spoken too quickly. I see some comments about speaking too fast, but we have tried to answer as many questions as we can in a short time.
So I don't think that there is any
Q&A. Let's see. Okay, so we have.
Marco, I think that it's okay. It's okay to start SGLT2 inhibitor non-diabetic only with albuminuria, Professor Wheeler?
Well, as I showed, the MEA kidney study did include patients with eGFRs between 20 and 45 who did not have albuminuria. Those patients gained, of course, those patients are at lower risk. Let's remember that. They're at lower risk because they haven't got albuminuria. They're at lower risk of kidney failure, and they're at lower risk of cardiovascular events. So it's quite hard to show a benefit in those patients. If you look at eGFR slopes, you will see that those patients progressed a little more slowly if they were on SGLT2, that's empagliflozin, compared to if they were on placebo. So there's a little signal there suggesting those patients might benefit. But the event rates are so low in that population that it was difficult in the trial to show a clear benefit of randomization to EMPA. Only the only signal was looking at the eGFR slopes in those patients.
There is another question in non-diabetic CKD in which dapagliflozin can be used apart from IgA. I think that there is many trials are ongoing now, adding SGLT2 inhibitor with the endothelin receptor blocker, as Professor Viraj mentioned, that any CKD patient, whether related to GN, focal segmental glomerulosclerosis, probably can include membranous nephropathy patients. So I think that any CKD patient without reference to the primary cause can be a candidate for SGLT2 inhibitor therapy. And there is very interesting ongoing trials about that. So a well-controlled diabetic patient with no CKD having a family history of heart disease. Can I add APG, I think, as gliflozin to that? Professor Amr, can you answer this question?
I didn't hear the question, what?
A well-controlled diabetic patient with no CKD, having strong family history of heart disease.
Yes.
Can I add an SGLT2 inhibitor for him? Can you answer this question?
Yes,
sir?
for sure. You can add SGLT2 inhibitor for the cardiac state and for chronic kidney disease also, but you have to reassess the medication for diabetes. If he is on insulin, you have to reduce some dose. If he in oral anti-diabetic drug, you have to reassess and strict glycemic control for management for fear of hypoglycemia. SGLT2 inhibitor doesn't cause hypoglycemia, but may another medication the patient is on, either insulin or sulfonylurea, it may cause. If you will add SGLT2 inhibitor, you have to reassess the other medication the patient is on.
Okay. Hello, doctor. So I want to know what diet can be given. We just answered this. Is there a specific monitoring symptoms or lab to monitor to prevent SGLT2 inhibitor adverse effects, Professor Wheeler?
Well, I think looking for ketones is one thing we've already talked about. if your patient, you know, we shouldn't be starting these drugs in patients prone to ketosis, so type 1 diabetics, or patients perhaps with a history of ketoacidosis. But if you've got a patient you're worried about, teaching them to measure ketones. But I don't think there's any other biomarkers for, you know, that will predict the negative or harmful effects of these drugs.
Thank you, Professor David. The question's for you, sir. I think you are reading it. How good are AC inhibitors to be used as adjuvant medication to renovascular disease patients, I think? Renovascular disease patients, in order to protect or stop proteinuria or progression of renal disease? I did not get the RVD. The RVD, what's the meaning of RVD? Renovascular disease? No. So please, if you can rearrange your questions without the use of abbreviations, so we can answer you, please, sir. How do you manage that? Is there any recommendation for starting DAPA in diabetes insipidus, Professor Wheeler?
There is a little bit of anecdotal clinical information around the potential benefits or potential effects of SGLT2s in diabetes insipidus, but I've not seen outcome data looking at clinical endpoints. And it's not really an area of expertise for me, so I don't know. Others may know, but I don't know whether this is a good strategy.
Dr. Amr, can we use oral bicarb for compensated metabolic acidosis? The question is for you, sir.
Yes, only we can use oral bicarbonate for severe metabolic acidosis. There is no data if the serum bicarbonate is 22 or more. We have to take care for when you are giving bicarbonate to the patients for the hypertension, and also if it is potassium based for the hyperkalemia. This is regarding bicarbonate state, and you should recheck the serum bicarbonate every now and then to avoid overcorrection of the metabolic acidosis of the patients, not empirical.
And this is again for you, Amr, please. It was two-parted questions. One of them, yes. What is, if you don't have a readily available serum bicarbonate estimation at the clinic, for example, so do you recommend giving empirically sodium bicarbonate? I think the answer is no. You cannot empirically give them. So can you recommend empirically giving a low dose sodium bicarb for CKD patients without estimation of serum bicarbonate, Professor Khalifa?
No. The answer is no empirical serum bicarbonate for CKD patients.
And the second part, there was a medication. I think that it was given by some the ketorologs. I think the essential amino acids to prevent progression of CKD, which is out of the scope of this. Do you recommend that? There is some medications that
regarding the alpha keto analog. Regarding yes. The alpha keto analog, there is some few clinical trials for as add-on on dietary management, but it is not reached to guidelines or recommendation. Yes. It is only clinical trial for the alpha keto analog that may decrease urea level in some patients, but it should be also accompanied by protein restriction. But to reach a guidelines, no, it is not a guidelines to give alpha keto analog for the patients.
Professor Abdullah. Professor Abdullah, you are with us? Abdullah Maliki? Professor Abdullah, what are the side effects of SGLT2 inhibitor therapy when the GFR is less than 20, and for that reason we are contraindicating it? Professor Abdullah, please.
I think it's not a matter of side effect, as Prof. Wheeler says. It's just how the drug will work. If the mechanism of action is through the kidney, So that's the way the trials were designed. The initial trials were actually at higher eGFR, 25, but with more recent data, the cutoff is 20. And that's why we don't need to stop it until the patient reaches end-stage renal disease or the patient becomes intolerant to it.
Thank you. Thank you. Okay, it's for all. Dr. Tanur, this very interesting question. I think that I need more than an opinion. For sickle cell disease, what do you think the pathophysiology will happen when you block the SGL2?
It'll be interesting. I'm not sure we've done any studies looking actually at patients with sickle cell. But I would be worried, I mean, because of the pathophysiology and what happens at the medulla and also for sickle cell disease is concerned. I am not sure how beneficial it would be, but again, that is just coming from opinion, in the sense that they are a peculiar group of people, and because of the vascular nature of what goes on, even simple things like response to erythropoietin is actually so poor in these people, more especially when they develop, nephropathy. So I would be a bit concerned, I mean, as to whether they would benefit that greatly. More often than not, when they run into proteinuria, and indeed, they actually do a lot of heavy proteinuria where it is actually so difficult, even with AAC, inhibitors, ARBs. But nonetheless, if I am to get a patient who can afford SGLT2, I'll actually put them on. But I'll be happy to see if there are any studies that can confirm this.
Thank you, Professor Abdullah. Any decrease in the requirement of diuretic use with SGLT2 inhibitor therapy?
Requirement of?
Requirement of diuretic use can be reduced with SGLT2 inhibitor therapy?
I think this is a case by case, especially, I mean, management, especially for heart failure, for cardiac patient. So if we have somebody on good dose diuretics and he's euvolemic, probably I would reduce the dose.
Okay. I think that we are. I think that this will be the last question that I will, because of the sake of the time, if we can briefly revisit the indications for SGLT2 inhibitor therapy. Thank you, Professor Wheeler.
Yeah, I'm very happy to do that. So let's remember that these drugs were designed to control blood sugar in patients with diabetes. They certainly do that if kidney function is reasonably good, that is GFRs of sort of greater than 40. But by putting patients on these drugs, we also can protect their kidneys and their hearts. And I think the strongest indications for these drugs are in patients with kidney disease, particularly those who have albumin or protein in their urine. And we can treat those patients or start those patients on these drugs with a wide variety of different kidney diseases, right down to an eGFR of 20 mil per minute. So that's where we would start them. In heart failure, if you've got patients, whether they've got preserved or reduced ejection fraction, then my colleagues in cardiology are starting these patients on SGLT2 inhibitors, whether or not they've got type 2 diabetes. So there's a really broad range of indications for these drugs that are not just diabetic drugs, but that protect the kidney function and protect the heart function, both in patients with and without type 2 diabetes. And if you think about that, that is an amazing list of benefits from a single class of drug.
Okay, thank you a lot for the discussions. I was very delighted for this meeting. I'm just hearing very nice information and nice discussions from all the speakers, and thank you a lot. And I hope that we will end the session today. And thanks a lot for all the speakers, and thanks a lot for the attendees, and thanks. And I should apologize if I forget one of the questions that cannot be answered because of the time. And thank you a lot. Thank you.
Thank you very much. Bye.
Bye.
Thank you very much.
Recording stopped.